Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hey Tom, good to see you once again.
Parker, time flies.
Yeah. You're wearing the same clothes that I saw you in last week. Wait a minute.
Oh, man, what's going on here? I guess this must be my Thursday shirt.
No, only kidding. So welcome back to the Sit and Stay podcast. We are here for our second part to talk about the setting up a charge master for your practice. And we just wrapped up part one, and now we just jumped right into part two. So that is why we are wearing the same clothes as last week. If you're listening on audio, I hope that helps explain the joke. So we dived pretty thoroughly into a little bit on the charge master, CPT codes, relative value units. So the next question to just get us going would be, how can practices use RVU and CPT data to optimize their billing processes and ensure fair compensation? Take it away.
Very good. Yeah, good question, Parker. And I think I'm going to start by explaining how I've always created my charge masters. And we went through a lot of details about relative value units and CPT codes. And the reality is, if you're a therapist or psychologist, there's probably 6 to 7 CPT codes that are all you're really going to use for billing your practice. So one great thing about psychiatry, psychology, therapy is those hundreds of thousands of CPT codes, we don't need to worry about very many of them. If you're a non-prescriber, you've got 10 or less, really. If you're a psychologist that does some testing, you've got a few more. And if you're a psychiatrist, nurse practitioner, physician assistant, or you use the E&M codes that prescribers use, you maybe got 11, 12, 13 codes that are going to be your bread and butter. And even the reality is there's kind of one set charge for new patients and one set most common codes for recurring patients, which makes life a lot easier for us versus running a pediatric practice or primary care practice. So what we do in our practices is we make a basic charge master with the codes that people are going to encounter. And I'm actually going to glance over at our charge master right now. And the reality is, for our group, we really only have 15 CPT codes for different services that we list. And most of the time, there's 5 different code combinations. That is the majority of our billing. So when you're setting up your charge master, you're going to go through and write down the codes that you plan to use for your billing. Specifically for our group, we have the medication E&M codes, which are for new patients 99, 203, 204, 205, and for established patients 213, 214, and 215. And then we have psychotherapy add-on codes 908, 33, 36, and 38. We use 90792 for intake appointments. We use the 90785 interactive complexity code. We occasionally use 90846 and 47, which are family therapy with and without patient codes. There's a group therapy code, 90853. And then there are billing codes for giving questionnaires, which is somewhat new in the CPT, being able to be reimbursed for these. Medicare just decided a few years ago that providers should be reimbursed for doing questionnaires. Right. And we use 96127, 96160, and 96161, which includes giving a parent a questionnaire about their kid, and we work with lots of kids. this is an often overlooked source of revenue
Right.
for providers, and something that we try to make easy in RipsyTech to capture that revenue if you're going to give a questionnaire to see how your patients are doing.
Right.
But that's really the list of our CPTs. I think there was maybe 10 that I listed. So what we do for each of those 10 CPT codes, we go to the location where our home office is. If you have more than one location, you may want to pick the location where if you're going to do this method, where the Medicare RVU values are the highest. But we look up the Medicare RVUs for each of those CPT codes I mentioned in our location right now in Alameda County, California. And then we get that code number. And then we take those RVUs. And Parker, I mentioned Medicare pays about $34 per RVU right now.
Right.
We decide in our clinic, hey, Medicare pays this, we're going to pay X per RVU.
Okay.
That number should be at least twice what Medicare offers. And then depending on where
Really?
well, and here we're getting a little bit subjective, and this is just really maybe my advice on how to set it up. Let me put an asterisk by that. If you are going to work to negotiate with insurance companies to get reasonable rates, it is important to set your baseline charges for what you would hope to receive from your patients who are paying out of network or cash rates, but knowing that when you go to negotiate with insurance companies aren't going to give you the cash rates that you post on your website. So the usual negotiation is, here's our charge master rates. We'd love to be in network with your insurance. We'll give you a 30% discount on our rates for people covered by your insurance. And then it's a negotiation that goes back and forth. Historically, if you can get insurance companies to pay about half of what your charges are, then you've done a pretty good job in negotiating. And therefore,
Wow.
that's why I recommend you set your charge master to be, I wouldn't say inflated, I would say what people would be paying for cash services in your area. But
Got
then
it.
knowing that you would actually be happy or comfortable accepting a lower amount from an insurance company, which is good for patients and can bring advantages to your practice as well, which is why you're willing to accept a lower reimbursement.
Interesting. I've worked with you for a long time. I've worked with, psychiatrists, therapists, psychologists, etc. for a long time, and I always hear about, negotiating the rate with the insurance company, but, for me, I had never really registered it as an actual negotiation. And, they don't use that word for no reason. It's interesting.
Yeah, like you're not going to be able to negotiate with the Medicare payment rate, but
Right.
Business is business, and every commercial insurance company will negotiate. I would say it's a business tactic on the insurance company's part to make people think they won't negotiate. But I swear that there have been insurance companies that send out their first rate offer and say the rates are non-negotiable. And then I write back and say, here's why we deserve more. And magically, the rates that were non-negotiable tend to go up. And again, we're in a supply and demand economy where there is more demand than there is supply for mental health treatment. So this is something that can be used to your advantage when you're trying to negotiate rates. And, when half of all people are paying out of pocket for their mental health treatment, that is definitely a supply and demand issue. Yeah. And so we want to empower clinicians to understand that and to go in as negotiators with insurance companies to get fair reimbursement.
Gotcha. I mean, I feel like we could do a whole episode specifically just on strategies for negotiating with an insurance company. Well, hopefully the insurance companies aren't listening. Pick up the strategies.
I'm sure they're already aware of the strategies, but yeah, that could be a great a podcast topic. Yeah.
So what would you say are some of the most common pitfalls that you've experienced when it comes to managing your charge master and your CPT codes? Are there ever billing errors, revenue loss? How can stuff like that be avoided?
Yeah, and let me talk about something that it is specific for prescribers or physicians with the CPT code billing, and it's worthy of a few minute discussion because it is a pitfall, as you mentioned, and something that a lot of providers do that is not recommended as a best business practice as a mental health prescriber or physician. And that has to do with these E&M codes. So I think I mentioned these E&M codes. I'm just going to talk about the ones for returning visits, which is 99213, 214, and 215 are the most common codes.
And that stands for evaluation and management, correct?
Correct. And these are codes that your specialized training in medical school or physician assistant school or nurse practitioner training, it doesn't just mean medication management. It means using those skills that you've developed in medical school in treating your patient. And that's a common misconception. So you can still bill these codes if you're not prescribing medications to a patient, because all these codes mean is you're using that skill that you developed in medical school in the evaluation and management of your patient. It doesn't mean you're prescribing medicine. So that's an important distinction. I always make the point of calling it E&M visit rather than a med management visit, because we want to make sure that our providers are clear about that. In reality, it's something that's probably confusing for the general population to understand. And, when we do see patients just for shorter medication visits, we will tend to call it a medication management visit for the patient. But that being said, the complicated piece for these codes is there's two ways to bill the codes. The first way and the correct way to bill these codes is based on the complexity of the patient and the visit that you've just done with the patient. So if you're seeing a patient with multiple issues, a patient where you are prescribing medication, a patient that's a minor and comes from a complicated household, if you're ever dealing with suicide or self-harm or have to think about hospitalizing a patient, these are different factors that go into deciding how complex the visit was. And 99213 is called a moderate complexity visit. And I'm just going to glance over real quick.
We're still here.
We're still here. Sorry, folks. I'm wrong. So 99, that's what I wanted to check because I felt like I was using the wrong terminology.
I see.
So 99213 is an expanded problem-focused visit, which it's hard not to achieve a 99213 for any visit as a physician or prescriber. 99214 stands for detailed. It's very easy, especially as a psychiatrist, to reach this level of billing. If you are prescribing medications, you reach it. If there's social or other complex factors that go into the social factors when dealing with your patients, you can hit this. And the 99215, which is the highest bill code, is for a comprehensive visit. And this is where you have some of the more intense sessions, do you need to hospitalize, were there self-harm thoughts? Was the session very, very difficult? Does the patient have a lot of mental health problems? That's how you determine how you can build these codes. And these are not time-based. So this is, you could see a patient for 5 minutes, and that could be a 99215 visit. It is all based on the complexity that you went through when dealing with the visit. It's something that can be confusing for people. It's one of the features I'm proud that we put into RipsyTech is a little, E&M predictor where if you write your note, our software will scan your note and let you know what it thinks the correct bill code is based on what you put in the note. But definitely, as psychiatrists, you should always be billing these codes based on complexity. The other way you can bill these codes is based on time. Mm-hmm. So in the time-based codes, the 99214 is 30 to 39 minutes. So if you spend 32 minutes with the patient, you could just bill a 99214 based on the time you spent with the patient. However, these time standards attached to the codes were really developed for primary care providers, so pediatricians or family practice or internal medicine doctors that spend a lot of time counseling a patient about diabetes, weight control, asthma treatment for the kid. That's why the times were set up for these codes. And if you've been trained as a psychiatrist or trained in any level to do therapy, we all know that even if you're doing appointment discussing medication with your patient, you're always engaging in at least supportive psychotherapy, and often you're pulling in other therapy techniques. And that's where the psychotherapy add-on codes come. And there's a psychotherapy add-on code, the same way we mentioned last episode, the 90834 was the 37 to 52 minutes for non-prescribers. There is the 90836 add-on code that is the 37 to 52 minutes for the prescribers. So if you're seeing a patient for 45 minutes, whether you're doing the medication or the medication and psychotherapy, you should be building the E&M code based on complexity of the visit, and then the psychotherapy add-on code, and potentially the interactive complexity add-on code if it was an intense session. And that's the right way to bill for the visit.
Okay, so to kind of go back around to the original question, are there any other common pitfalls that anyone might experience that could also lead to, gaps in revenue or any kind of errors in billing?
Yeah, great. And it relates exactly to what I was just talking about. So, if you're doing a cash practice, and it not just for cash practices, but I know other big institutions as well that tend to only bill those 9921, the complexity codes based on time. And I can see the appeal of this. If you're a cash practice, you're seeing a patient for 30 minutes, it's always just going to be this one code. And then you bill, let's just say you bill $200 for a 30-minute visit, and your patients are always going to get a super bill for a 99214. Then I don't know if we've talked about super bills yet, but a super bill is if you see patients, not today at least, yeah. If you see patients for cash, you are required by law to give what's called a super bill, which has information about your practice, your license number, the CPT codes used in diagnosis. And that patient can take the super bill and submit it to their insurance themselves, and they might get some out-of-network reimbursement. The reason I really don't recommend just billing E&M codes based on time are, number one, even if you would charge the same cash rate, you're hurting your patients by not doing a complexity code plus a psychotherapy add-on code. So that patient is going to get more reimbursement if there's two different codes there that each have a charge added to it. So that's the first piece. But then the second piece as well is you're shorting yourself on what you should potentially be charging your patients for your services if you're just going to bill by time, because then if you could have a very easy patient that is low stress, and you're getting $200 an hour, or you could have a patient who's in very severe shape and you need to call the hospital and it's very stressful and you need to reach out to other people. And then you're missing out on reimbursement that you should be entitled to if you're billing by complexity plus therapy add-on codes. So that is a very common pitfall, and what I would say is a mistake in a way a lot of people set up their charge masters and charge for their practice.
So in a lot of ways, it's more beneficial not to bill based on time for it seems like everybody.
Definitely, in my opinion, I think it's better for providers and better for patients. There are certainly situations or scenarios where maybe there's a reason to do that, and I wouldn't, there are multiple ways to do things, and I wouldn't, I want to maintain my humility in thinking that there are possibly situations that I haven't thought about, and maybe someone can send in a comment to us at sitandstay@RipsyTech.com about why they think you should only bill E&M by time, and we'd love to hear those scenarios and talk about it.
Yeah, absolutely. So just to move things along a little bit, how often would you recommend a practice review and update its charge master CPT codes, RVU values? Earlier you were talking about the number for 2024 or the number for 2023. Is it primarily on a year-to-year basis, or are there any other kinds of types of triggers for those values being updated?
Yeah, great question. And so Medicare does tend to update the RVUs on a yearly or sometimes twice yearly basis. Should you update your charge master yearly? I would say at the longest time period I would recommend going without updating your charge master is maybe 3 years. I think it is very reasonable to update your charge master on a yearly basis. That is what Medicare does. I will say that we are still using 2023 values, and I think that is because we just relaunched some services through a nonprofit agency that I work through, and it feels too soon, to update the charges, and so it's something we'll probably keep the 2023 values and not update the charge master until 2 years have passed. But given inflation and the economy and other factors that have been happening, it is very reasonable to modify your charge master on a yearly basis. I'd say, look around at other businesses in the community. People tend to sometimes modify how much their sandwich costs or how much car repair service costs, depending on what they need to pay their employees. There's new minimum wage laws in California for healthcare workers that could be affecting some mental health practices that you have to deal with. I think the most important thing is you want to give a lot of notice to your patients before increasing your rates, especially if you're a cash practice. But even if you're an insurance-based practice, for those reasons we talked about, for the people who have co-insurance or high deductibles, they need good notice to know if your rates are going up. And I think in general, people go into fields like this to help people, and it can be an uncomfortable situation taking money from people who are suffering that you're trying to help, but
Right.
keeping it straightforward and emotion out of it. And I think most people understand it's still a business, and just being reasonable about how you set your charges when you update them.
Communicating.
Yeah. And I will say, before you decide your type of practice, are you the type of, you need to think about your personality a little bit, and would you rather, and I'll speak for me personally, I'm very happy when someone can just pay their $20 copay and get services. That feels, healthcare is a right, and they don't see all the hassles on the back end we go through to deal with insurance, but the payoff for the patients is worth it there. I have a harder time, taking a hundreds of dollars payment for services, just personally. So it's something important to know about yourself in your practice.
Yeah, no, I mean, that's very, very, very understandable. And I'm glad you brought that up. So when it comes to we are dealing with a lot of numbers, and a lot of it involves the insurance company. Some of it involves the state. So how do you make sure that your charge master, your RVU amounts, and for your CPT codes, how do you make sure that all of that complies with any regulatory or insurance requirements that might be out there?
Yeah, great question. And the first piece is to make sure that you're billing your CPT codes correctly. If for non-prescribers it is easier because it is a lot of time-based billing, maybe some complexity add-ons, and it's easy to document that in your notes. The good news is it actually got easier to document some of the complexity standards just a few years ago. So it used to be much more complex, and there was a lot of audits and denial of payments to all healthcare providers based on very sophisticated rules on documenting complexity. But that has been reformed, and so now it is much easier to meet those guidelines as a psychiatrist or prescriber. And in our general notes for RipsyTech, we have a section called medical decision making, which is essentially where you justify what you bill for the complexity codes. So you fill that section out, and you can make sure that you're, with our tool, that you're meeting the complexity guidelines. And then, if you're billing for a 37 to 52 minute add-on, make sure you documented that you saw in the how long did you spend in therapy with the patient, make sure that number falls between that range.
Right.
And so you want to make sure that you document that piece properly. I think the other thing to be aware of with regulatory concerns that you mentioned, Parker, is I see a lot of practices don't have consistency around sliding scale policies or courtesy discounts. And this is probably one of the biggest regulatory issues or ways that a practice can get in trouble. You're not allowed to just randomly see a patient and decide, I like this patient, I don't like this patient, what percent discount you're going to give off your services. Mm-hmm. So your clinic, and even if your clinic is just your private practice, you need to write down an established policy for whatever discounts you're going to give and how you're going to base those discounts. It might be as simple as, if you're coming and you're doing self-pay and going to submit your super bills yourself, you get a 25% discount off our basic charge master rates. It could be, hey, if you're coming to our clinic and we're primarily an insurance clinic and your insurance is out of network, we're going to give you a 40% discount. It can be, if you're coming to our clinic and you're on Medicaid, you're going to get a 60% discount. And to prove you're on Medicaid, you're going to give us a photocopy of your Medicaid card.
Right.
And then it can continue to get more complex with, we're going to look at federal poverty guidelines and see where your family falls, and then give a percent discount based on federal poverty guidelines. Although then you get into, are you going to ask people for their tax returns, for their W-2s, for their assets? So you've got to decide, what you're willing to do documentation wise in setting these discounts. But the most important thing to be aware of is you can't just be random with setting out discounts, because it can be discrimination.
Right. So it's got to be systematized in a way that is also well documented. Correct. Awesome. So anything else that you'd like to add on this topic? We've covered so much already. Anything else that's lingering in the back of your mind?
Yeah, no, I think it's good basics. I think the topic of negotiating with insurance and how your charge master relates to that, and how you can use the Medicare RVUs to strengthen your position in establishing your worth for the visits you provide, it will be a good topic. But yeah, for another podcast. And what I would say is, if you want to see I do recommend everyone go and look up the RVUs for the CPT codes they charge. You can go to the cms.gov website, and then if you click the search box, it's actually called physician fee schedule. But it works for all CPT codes, whether or not you're a physician. It will get you the RVUs, and then you can put in the CPT codes you want. You can put in the region you're in, and it will spit out a complicated spreadsheet row or rows you can download that you can use to see what the RVUs are in your area for those CPT codes. So everyone should go ahead and do that. And yeah, please reach out to us if you have specific questions after doing that. We'd love to answer them. But that would be a great exercise for people. And then if you already have your charge master set, divide that dollar value by the RVUs, and that should be consistent per RVU, and see if that matches up to what your charge master is.
All right. Yeah, that is great advice, and thank you for being so detailed. We've covered so much in what for us has been almost an hour, but for the listener maybe two weeks worth of episodes. And I also appreciate pointing out, reach out to us, reach out to sitandstay@RipsyTech.com. Send us your questions. We would love to answer them on the podcast. It's a great way to engage with us. We would love to boost the voice of our audience as much as possible. So with all of that being said, I think, would you like to cover the mental health business moment of the week?
Yes. A business moment of the week. So we just added another practitioner to our group. Mm-hmm. And when you're adding a new practitioner and you accept insurance, there's a process to make sure that practitioner is both credentialed with the insurance and then contracted with your agency. And you want to do your best to make sure that happens before they see their first patient. And so I feel like I'd gotten pretty good at this after many, many years. And to the point where we had email communications from different people at a major insurance company confirming, yes, don't worry, this provider is registered and in network as of this date. But then, of course, they saw their first patient and we submitted the insurance claim, and 2 days later, boom, you are out of network.
Oh, no. Yeah.
And so, then it's no money is being paid, and a big bill would go to the family, which is not going to happen, but it's just, hey, here's the email that said the person was in network. We just saw a patient. It was out of network. And now it's going to be who knows how many weeks and how many, hopefully not hours of time, but it's going to take a while to sort this issue out. And we'll we won't bill the patient out of network or anything like that. And we'll just sort of keep our fingers crossed that we can resolve this with the insurance company and ultimately get paid. So that is the complication hassle of the week.
Well, yeah, there never seems to be any shortage of complications and hassles that one might never expect. So, for as long as there are moments, we'll keep providing them. So, thank you, Tom. Well,
thanks, Parker.
I think that does it for this week's episode. We appreciate everybody tuning in for both hopefully you caught part 1. If you not, go back and listen to it. But yeah, this concludes part 2 of talking about charge masters right here on the Sit and Stay podcast. So as mentioned, please go ahead and send in your questions to sitandstay@RipsyTech.com and go ahead and check us out at RipsyTech.com as well.
Very good. Thanks, everyone.
All right, thanks, Tom.
Parker. See you soon.
Catch you next week. Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.